This is an example of a client who presents with some of the components of what I named the most common pattern of faulty lumbopelvic hip motion coupling. We did some work on the joints in the left ankle and also the superior tibiofibular joint, which is the topmost joint where the fibula and the tibia connect on the outside of the knee and just below that. And we did some work restoring normal glide of the left distal femur. So we treated knee and ankle, and now we're focusing on the pelvis and on the hip. Sometimes someone who has what I name the most common pattern has a glide dysfunction of the whole pelvis, but she moves well when I take up the slack going right to left, and then I impart a passive little impulse of force transmission, and she moves well in both directions. Another common restriction with this pattern, which she also does not present with, is that of restricted internal rotation of the hip as measured with the client in supine. We're going to measure that also when she is lying on her stomach. When I palpate the pubic structure coming down from the belly down to that bony structure, there's equal height walking across the left and right pubic bone. And here's an example of that joint. So belly button is right here. You come down to the soft tissue and land on that joint here. However, when I compare right to left side at the upper third, middle third, and lower third, the left face is posterior, and I feel a step down going right to left, and I feel a step up going left to right. When I impart force transmission through the right bone, it doesn't move. When I do so on the left, it does move that way. This is a behavior of the pubic joint which I discovered many years ago, and remarkably, it's not described in the literature. It is a pattern that is somewhat common, and another pattern that is described as an upper joint pubic rotation about a transverse axis actually does not exist. When one encounters that pattern, if you then go and palpate the middle third and the lower third, you'll find out that a shear is actually what presents as that pattern. We'll test the pubic joint when she is lying prone in a different manner, checking ligamentous tone and checking force transmission through the ischia, because of course ischium is here and it's seamless with the pubic bone. Those fuse somewhere around, between the age of 15 and 25. The pelvis stops forming, and quite some time before that, these the three joints that form the hemipelvis, ilium, ischium, and pubic joint, fuse. But the ligament that goes from this point on the ischium, called the sacrospinous ligament, goes from the spine of the ischium across to the sacrum, and that one is altered when there is a transverse plane or an anterior to posterior change in the relationship in the pubic joint. So we'll demonstrate that as well. This ilium looks like what's called an anterior ilium. I'm not suggesting that the ilium is rotated inside the SI joint, because the pelvis can move in three-dimensional space without any altered relationship inside the SI joint. So we're not calling this a sacroiliac joint dysfunction. I'm calling this a pelvic asymmetry, and we're going to try and find out if it's treatable. This ilium is lower than this side. On the left side, I can take up slack through that structure and induce a rotational mobility, but it moves very strangely. Typically, this does not become elevated and move medially to any significant degree. So even though this moves on the left side, even though there is force transmission, there's definite aberrancy in contrast with a typical response. On the right side, I cannot take up the slack in the system. It's very, very tight already, so there is no normative force transmission, and we'll come back and measure that and see if that is a changeable property. But let's have you lie on your stomach. And you can rest your face in that opening. I'll block the film momentarily. So now that the client is lying on her stomach, I'm checking the flat part of the ischium in the lower third of the buttock, and this ischium is a little bit posterior. And if I try and induce force transmission through this structure, it doesn't move. It feels very rigid. On this side, and my direction of force, regardless of how my hand looks or my arm looks, is posterior to anterior towards the floor. You'll see that I can take up some slack. It's a very strong structure. And now if I attempt to spring it, you can see that there is force transmission. It's pretty subtle. I don't know if the camera actually sees that, but I can feel it and I can see it. Okay? So checking the posterior pelvis, this shelf is inferior in relationship to the right. Okay? And walking along the sacrum, it's too subtle for me to say that there's any discernible asymmetry. Same with underneath it. And interestingly, I don't discern any significant asymmetry at the ischial tuberosities. Now on this side, noteworthy is the fact that I cannot induce movement going superiorly. And this is quite atypical, because when you usually see that pattern that they name anterior ilium, usually it can move that way freely, and so it's surprising to note that this doesn't move. It's surprising to note that under the ischial tuberosities, if there's an asymmetry, it's so subtle I don't see it in terms of height, and yet there's a very distinct asymmetry up here. So when I see something that doesn't quite fit the typical pattern, it's noteworthy, and I'm about to learn something. If we evaluate anterior rotation, you can see that I can take up slack in the structure and induce some mobility. And on this side, on the right, I'm not able to do so. I'm not able to take up any slack. And if I double or triple the force, and the direction of my force is towards the floor, nothing yields. If I do an inferior glide force transmission test through the pelvis, through the pelvic structure, the hip, the lower extremity, I know that you can't see it, but I see her foot bobbing up and down. On the right side, I attempt to take up the slack. I'm doubling and I'm tripling the force, and nothing's happening. So it could be that this is well, we're going to call it a fixed deformity, but it's just simply how the body is. I don't really like the word deformity. It's an asymmetry from side to side, and there isn't a transfer of mobility on this side, regardless of direction of that spring test. I did say I would come and evaluate ligamentous tone, especially the sacrospinous, but I'm first testing the sacrotuberous ligament, and that's a very big ligament, connects the infralateral angle of the sacrum down to the medial part of the ischial tuberosity. Not much difference there. And the sacrospinous should be right here. On the right, I can indent that. And on the left side, it's very tight. Okay, this feels much more like bone, and I'm doubling the force that I put through it, and it doesn't spring. So this ligament is very tight like bone, and it'll be interesting to see if that's a mutable property, see if that changes with attempts to alter the orientation of the pelvis. Why are we doing this? Why do we even care about an asymmetry of the pelvis? It has to do with her sitting comfort. It has to do with the fact that in her job she is required to sit for very long periods of time as an attorney. And it also has to do with the fact that she does have some ankle, knee, and hip issues. And so we're trying to see if the biomechanical model is a fit, if that accounts for some of the discomfort that she has. And there's a lot of communication on the internet about supposedly the biomechanical model is no longer relevant, and it just doesn't make any sense. It's as valid a model as any other model. There isn't a separation of a biomechanical and a pain model. They are all integrated, and the body works as an integrated biomechanical structure. And we continue to learn more and more about the science of biomechanics and arthrokinematics, movements inside joints, and how that relates to individuals. And when it's a fit, it's a fit. When treating with a biomechanical approach helps function and reduces pain, then it's valid. When it doesn't, then it isn't, and it requires an approach from a different perspective. So I'm going to stop filming now. I'll continue to do some more assessment and see if there's any change that we can induce here, and we'll certainly evaluate how that, if that translates to improved function and reduction of pain. Thanks.